I can upload your presentation and then we can start.
Good afternoon. I can share my screen now.
I think there's someone who has the gadget on in the room where you are, so there's an echo.
All right, thank you. Is that better?
Yes, it's better.
Okay. So I can start sharing.
Yes, doctor.
This one. Good afternoon, everyone. Welcome to this journal club presentation. Presenting on behalf of Teaching Eye Hospital, Dr. Moka, STP3. Sorry, doctor, I seem to have a challenge with scrolling on the slides.
Yeah, Dr. Moka.
Yes, doctor.
Yeah, so you go to slide share and then slideshow, and then you can start. You can just click enter or the other arrow.
The one that one is already slideshow. So we click enter.
Yes, and then click slideshow.
Okay.
Yes.
Okay. Thank
we
you.
can see.
Okay. Thank you so much. So I'm Dr. Moka from Quito Teaching Eye Hospital. Today, our topic, we're going to be discussing primary orbital polymethyl methacrylate implants following primary enucleation for retinoblastoma, a study of 321 cases. This is an article that appeared in the online journal Orbit, published on the 7th of April, 2020, with a ranking, the journal has a ranking of 15,656 overall, and an impact factor of 0.52. So in our introduction, I'm going to give a few details concerning the key words in this article, which are retinoblastoma, enucleation, and implants. So as we know, retinoblastoma is the most common intraocular malignancy in children, with an incidence of 1 in 18,000 live births, and it is caused by mutation of the retinoblastoma gene, which is a tumor suppressor gene. This condition is curable, but potentially blinding and deadly, especially if detected late. So in developing countries, they have managed to reduce the mortality rate to below 5%, but in Africa, our mortality rates are still above 70%, mostly because of the late presentation of our patients. So we are missing them. So our approach to retinoblastoma, it is encouraged that it should be a multidisciplinary, multi-level, and collaborative approach at each level of healthcare, starting from the primary level all the way to the tertiary level. And this should include increased community awareness. The community should be aware about how to detect pathology in the baby's eyes and come to the center quickly. The facility staff, especially the primary level staff, have to be equipped with skills of early diagnosis, which will also enable prompt referral to specialized units for further treatment. It's essential to provide good counseling and quality treatment, because this is what will save life and also improve the uptake of services. If we give poor quality services, the community will not be encouraged to come. So this is why we're going to talk about it later in the presentation, the need for putting implants for a good cosmetic appearance at the end of the day. We don't want to just save the life, but we also want to improve the quality of life. So the first step to the management plan for retinoblastoma is a classification and staging, and this is also important for prognosis. The first classification system was given by Rees and Ellsworth in the 1960s, and it was based on they were trying to predict how well they can preserve an eye based on external beam radiation therapy. Later, with the introduction of intravenous chemotherapy in the 1990s, we saw the birth of the International Intraocular Retinoblastoma Classification, which has classes A to E. So in retinoblastoma for intraocular diseases, we are using the IIRC classification, the International Intraocular Retinoblastoma Classification, or the intraocular classification for retinoblastoma, as well as the TNM staging, which has a clinical and histopathology component. So the C stands for clinical and H for histopathology. For extraocular disease, we're using the IRSS and the CTNMH. So this table just shows the International Intraocular Retinoblastoma Classification, the classes, how it is defined, the different classes, how they're defined, and how they relate to treatment. So we see that for the smaller tumors, A and B, focal treatment is advised with or without systemic chemotherapy. But for tumors that are classified C, D, and E, we can see that enucleation is mentioned. That is for unilateral cases, and bilateral cases, we attempt first to do a second eye salvage therapy with systemic chemotherapy plus or minus focal treatment. And if this fails, then we proceed to enucleation. But I will not labor to give all the details concerning this table. I think we can look at it later. So I proceed to enucleation. So this was first described by Batish in 1583. And later, about 5 years later, in 1855, News described enucleation orbital volume replacement. So indications for enucleation include intraocular malignancies like retinoblastoma, a painful blind eye, severely traumatized eyes, unsightly eyes, and responsive endophthalmitis, to name but a few. Which are imbrication technique, the integrated implant technique, and my conjunctival technique, which we shall give more details. So these three techniques positioned during surgery. In the imbrication technique, the superior rectus is imbricated with the inferior rectus, the medial rectus is imbricated with the lateral rectus. In the integrated implant technique, the muscles are sutured around. Sorry, doctor, is there? I can proceed?
Yes, you can proceed, but it appears we still have some feedback. Is there anyone in the room where you are who has a gadget on?
Okay. Oh, yes, sorry about that.
Yeah, I think it had to do with interference.
All right.
Okay, you may proceed.
So the integrated implant technique, the muscles are sutured directly to the scleral cap or the mesh around the implant in the location corresponding to the. In the myoconjunctival technique, the rectus muscles are sutured just short of the respective borders, with sutures passing through the anterior tenons conjunctival complex. So these pictures. So these pictures, they show step by step this myoconjunctival technique. I think we can have a look at this later, but right now I'd like to ask Dr. Mumbi to share. Dr. Mumbi?
Yeah, so just give me a moment. Sharing so that I can share.
video illustrates enucleation by the myoconjunctival technique in a 4-year-old child with left eye retinoblastoma. The surgery is usually performed under general anesthesia. After the patient is prepped and draped, a wire speculum is placed to exclude the eyelashes from the field. A lateral canthotomy is performed. A 360-degree peritomy is done using a blunt tip viscose scissors, cutting as close to the limbus as possible. The underlying posterior Timon's fascia is undermined in all 4 quadrants in a spreading action using a blunt tip tenotomy scissors. Each of the recti muscles is identified, hooked and double tagged, first with 6-0 silk and then with 6-0 vicryl suture. 6-0 silk sutures serve as traction sutures, while 6-0 vicryl sutures would later be used to suture the muscles through the conjunctiva. Each of the recti muscles is then transected at a point between the 2 sutures. The superior oblique and inferior oblique muscles are transected and allowed to retract posteriorly. A conjunctival relaxing incision is made for easy manipulation. The eyeball is then prolapsed between the blades of the speculum. With a forward traction on the eyeball using the 4 silk sutures, a gently curved blunt tip tenotomy scissors is passed along the lateral wall and the optic nerve is trumped along the length. With one bold cut, the optic nerve is transected at the desired length. And when the case is retinoblastoma, as in this patient, the transection is performed just a little anterior to the superior orbital fissure. To gain a good optic nerve length and at the same time avoid fascia is closed with interrupted 6-0 vicryl sutures. Anterior Timon's fascia is closed with interrupted 6-0 vicryl sutures. Conjunctival closure is done in a continuous key suturing pattern with 6-0 vicryl suture. An appropriate size conformer is placed and a median tarsorrhaphy done with 6-0 vicryl suture. The suture tarsorrhaphy is removed after 1 week and a customized prosthesis can then be placed in the socket after 6 weeks to achieve an excellent static and dynamic cosmesis.
Okay, Dr. Silva, you want to make some comments on the video? Do you want to make some comment as you share the slides?
Oh, yes, doctor. So we have seen that this is a simple technique that's all we're all being encouraged to adopt, because we want a better prosthetic outcome for the child, and also it's documented to have better motility. So this is some. Okay, are you able to get this to see my slides?
Yes, please. You can see, you may proceed.
Okay, so care after enucleation. All right, thank you, doctor. So this pack for 24 hours, oral antibiotics, topical antibiotics, steroids, a switch to therapy, as we saw, and the customized ocular prosthesis 6 weeks post-OT. And we would have taken a sample for histopathology, and the results, if they show a high-risk features, it is advised that the child receives systemic chemotherapy. So we come to orbital implants. There are basically 4 categories of implants that are in use. The integrated porous implants, examples of which are the HA, the polyethylene, the aluminum hydroxide. HA means hydroxyapatite. We have the semi-integrated implants. These have got large gaps for muscle attachment, example the Allen implant. And the non-integrated, non-porous in which class we have the acrylic, the PMA, and the silicone implant, and the nerve of the battle, and implanted atrophy, and giving shows the porous important extrusion. Features.
Dr. Sylvia, we can barely hear you. Do you have a challenge with internet?
Sorry, it seems my connection went off. Okay, I will share my slides. This one, the slide is still there. Okay, is that okay?
Yes, you can hear you clearly now.
All right, thank you. So the more commonly used implants are the porous implants, and in this article, we are going to focus on the non-porous implants. Okay. Sorry, the slides seem to have frozen again. Just a moment, please. Mm-hmm. Sorry, we have the slide challenge with the slides. Okay. So the porous implants are the most preferred choice of the developed world, because, like I mentioned, they undergo fibrofusion of the implant, and known to have better motility. However, because of exposure, because the implant done by cast and ore, they show that comparable motility between both wrapped porous and non-porous implants. They motility alluded to earlier. They can be fat graft, fascia lata, scleral, marceline, or even polyusually have shown that the non-porous implants are associated with migration and extrusion because they don't undergo fibrovascularization. So there is nothing to anchor them within the intracornal space. However, like we saw in the video, looking for is a good outcome because it affects the child negatively if we don't use these implants in the long term. So we'll come to the consequences of not using implants. It's orbital growth retardation in retinoblastoma patients who underwent unilateral enucleation and radiation. This is because once we remove the growth, there's no stimulus for growth. So the orbital volumes in this study were seen to be significantly smaller than their age-matched controls. And the orbital volumes, additionally, they found that the orbital volumes of patients who were treated before the age of 12 months were significantly smaller than those that were treated after the age of 12 months. This is because this is a period when there's rapid growth, orbital growth going on. So once that is arrested, then we get that significantly reduced orbital volume. And the mean asymmetry index for the retinoblastoma patients in this study was found to be 14%, but in their normal counterparts, it was found to be about 2%. So this figure just depicts the reduced orbital volume associated with the enucleation, which we are seeing here, and also in this and there. So these images were obtained by CT analysis and 3D model reconstruction. So we come to back to our article, the objective of which was to evaluate the outcome of primary orbital polymethyl methacrylate PMMA implant following primary enucleation for retinoblastoma. So the study setting, this was done at LV Prasad Eye Institute in Hyderabad, India. And the methods, this was a retrospective case series between they reviewed medical files of patients between 2007 and 2018. So they found that 321 retinoblastoma patients underwent primary unilateral enucleation and had PMM implants put. And all of them had enucleation by the myoconjunctival technique. So under the methods, they took note of the demographic details of these children. They looked at the age, the gender, the clinical history. They considered the laterality of the affected eye, whether it was left or right, and also the grouping of retinoblastoma by the International Classification of Intraocular Retinoblastoma. They also took note of the history of pseudo-orbital cellulitis, the diameter of the PMA implant, the horizontal diameter of the socket conformer, any intra and post-op complications, as well as a record of external beam radiation therapy for those that developed secondary tumors. In the methods, they also looked at implant extrusion, implant exposure, implant migration, socket contracture, and also the management of the complications that arose during this period, and any details of the second surgery that the children underwent. So in this study, they considered enucleation by myoconjunctival technique with implants placed in the intracornal space with the extraocular muscles anchored to the conjunctival cornices with absorbable sutures. That was what they considered as the myoconjunctival technique. And implant extrusion was defined as total loss of the implant, while implant exposure was defined as conjunctival wound dehiscence with exposure of the implant. In the inclusion criteria, required a minimum of 40 months follow-up with the adequate data, as I have just come from elucidating. And the exclusion criteria was just written as less than 40 months follow-up with inadequate data. There was no mention of the data collection tools and analysis the analysis tools that were used in this study. So the results show that the mean age at enucleation for these children was 35 months. The ratio of male to female patients was about 1:1. The laterality was also, for the left and right eye, was about 1:1. Is that a comment? So I can proceed. So most of
Yes.
the children, most of the subjects for this study fell into group E. We saw that 82% of the 321 eyes were falling in group E, while only 18% were falling in group D. But all these children underwent unilateral primary enucleation. The median, the mean implant diameter was also taken note of. It was about 18, and the conformal diameter was 24. For those that had excessive intra-op bleeding, there are only 3 cases, and only 11 had pre-op pseudo-orbital cellulitis in their history. Other features that they took note of was post-op external beam radiation therapy. This was undergone by 7 of the study subjects. And when it came to the implant details, we found that over 91% of these subjects had good implant centration. However, 9% had implant migration, and most of this occurred in the supratemporal region because there is little support in that area. Implant exposure was seen in 2% of the cases, and implant extrusion in 3% of the cases. Socket infection was seen in only one study subject, and contraction was seen in 4 cases, and only one of these patients had grade 4 socket contraction. For the complications, we had 10 cases of pyogenic granuloma. There are 10 cases of pyogenic granuloma and 1 preconjunctival cysts, which were attended to. So when they compared the findings of this study to other similar studies done for non-porous implants, post-enucleation in children, we see that Christmas and all, this study here has a finding similar to what they found, where there's they find that the non-porous implants are associated with increased migration. Heman and O and Lee and others, and Morris and all the other 3 studies found that these non-porous implants were associated with more exposure, which is associated with porous implants. So the author's interpretation was that the use of unwrapped non-porous PMA implants following primary enucleation in retinoblastoma patients provide good post-op outcomes, which is comparable to that of porous implants. And they also achieve good, acceptable, customized ocular prosthesis and motility, which is what we're looking for in the long term. And that the myoconjunctival technique provides implant stability and reduces implant migration. There was no implant-related complications secondary to external beam radiation therapy. So we come to, may I proceed?
Yes, proceed. If there are any questions, we are going to ask at the end.
Okay, thank you, Doctor. So we'll come to the critical analysis of the study. So under methods, the study question was relevant and well-defined. They were able to define the study period from 2007 to 2018, and the sample size was clearly stated and adequate. The inclusion criteria was well-defined, the exclusion criteria was not well-defined, but it was just stated as having inadequate data. So the assumption is that all those listed variables should all have been present in order for you to be included in this study. Consent and also ethical approval was obtained as expected. For the assignment, this was a retrospective case series, considering all the patients that were enrolled during the study period, and they reviewed medical records of those participants. In the assessment, the aim was to discuss the outcomes of non-porous PMA implants following primary enucleation in retinoblastoma cases. However, the identity of the observers was not revealed, and the data collection tools and analysis tools were also not indicated. The measurement of the outcomes seems accurate at this. The results, the data was all presented, but there was no mention of any statistical tests which were used. And I feel the results compared reasonably well with the other related studies that they compared with. So our interpretation is that non-porous PMMA implants force enucleation for retinoblastoma. Sorry, their interpretation was that non-porous PMMA implants force enucleation for retinoblastoma have minimal complications and they provide good, acceptable cosmetic outcomes, which is what we're looking for. So we can extrapolate this finding to say the use of non-PMMA implants, non-porous PMMA implants is safe, cost-effective, and provides a good alternative to porous implants for our setting, because porous implants are generally more expensive than the PMMA implants. So with the use of the PMMA implants, we can make this procedure relatively cheaper for the patient and also for the facility. The myoconjunctival technique also is seen to provide better customized ocular prosthesis motility, which is what we are looking for at the end of the day for this child once we have provided all the care that they require. If we do not do that, then if we do enucleation without implants, we risk having, first of all, the growth retardation as we looked at, as we saw, and also a poor cosmetic outcome, which affects the child negatively and will affect them in the long term. So even as we save the life of this child and we want to do all that we can for this child, we have to make sure that we provide a solution which will help them in the long term and provide for their social and psychological well-being as well. Thank you. That's the end of my presentation.
Yes, thank you very much, Dr. Sylvia. It's unfortunate. I don't know whether it's Zoom etiquette. We are unable to clap. So if there was a way of, there's you know, some innovation, some additions that can be added to just show appreciation. Thank you very much. I know you have done this quite a lot. You put in a lot, and through our interactions, it has been very beneficial, I think, to everyone. Yes. I'd like to just to mention that we selected this article specifically to just highlight a few things. We do a lot of enucleations, and we also do a lot of eviscerations, more especially in children. And the ultimate, apart from saving lives, is that we need to attend to the cosmetic appearance of a patient. Okay, so yeah, so basically we can go ahead and do we remove the tumor and we save a life. And then, like I was sharing with Dr. Sylvia, that after we have done all these things and then the patient is not appearing well, because of that appearance, the patient commits suicide. So we have not achieved anything. And to be amazed of these implants, they're really so cheap. It's only about $3 one, which is like the current, that's a 20 kwacha. About, you know, about 60 kwacha currently, you know. So it is something that we can make a difference in the child's life. And then also, if you notice, just to comment on the video, if you have noticed that after they put an implant, they put a conformer. One of the reasons is that you keep that with a tassoraphy so that you maintain the phonesis. Because sometimes after you have gone through all this, the conformer will start falling off, and the child will need to be exposed to another surgery in terms of forming the phonesis. So at this particular point, I'll open the floor for discussion about the article itself, about what colleagues are doing elsewhere, and contributions generally. Yeah, so if there's someone wants to make a comment, you can just come in. Dr. Gwendakwem, I think you are trying to say something. We need to unmute you. maybe if you want to talk, you may need to click on unmute in case you want to say something.
Yeah, thank you. The presentation was very good and I indeed enjoyed it. It's just that many of us that have been doing enucleations and eviscerations don't seem to have the implants. Do we have any organized form where we can easily get the implants? The question is to you, Dr. Mondi.
Yes, thank you very much. I'm not sure for the people who have been practicing, but we noticed at UTH when I was there that we did not have much. So we have 3 suppliers. I think if you ask the people from UTH, they can give you the contacts from external people where they got them. Mostly these are Indian suppliers. I specifically got those contacts from Dr. Sam Moyo from Zimbabwe. So the cost was like $3 for the PMMA. PMMA is what she described it. And then the silicone was a little bit more expensive. So that's one thing also this article was trying to highlight, that we don't need to go for the very expensive one, like the silicone. Even with what we can afford, we can, because the ultimate is we need to preserve the facial symmetry like she has illustrated. So yeah, so I think maybe for now, for any contacts, you might need to ask UTH. I know they received quotations from those suppliers. They should be about 3 or so. If I find them from Dr. Sam, I should be able to send you the links. So what happens is that you order them and then they'll put them on DHL, so you'll be able to receive. And then if it's in private, the cost can be thrown to the patient. It's much more. Because I've seen that some patients are able to. There was one time when you're doing enucleation, the patient came from a catheter, I think. The grandfather moved around a lot. She was able to, but she could not find any. It was bilateral retinoblastoma. So we ended up enucleating one eye. The other eye, I don't know what happened. There was COVID. Okay. Any more comments from colleagues? Yeah, as we are receiving comments, I just want, I can see Dr. Evaristo Banda. Dr. Evaristo Banda, you just mentioned just one take-home message you have taken, and Dr. Brian, and then also Dr. Agnes, the 3 of us just mentioned just one take-home message that you are going to take into your clinic for practice. Either the way you're doing surgeries or the way these patients are managed. Yeah, Dr. Banda, we can start with you.
Thank you, Dr. Mumbi. Thank you, Dr. Silgamoka, for the wonderful presentation. The take-home message for me from this presentation is that PMMA implants can be used on our patients, and I think the patients can benefit. And also the procedure, the myoconjunctival route. Thank you.
Yes, please. The next person to comment for us. I think I remember I mentioned Dr. Grace. There's one more person I can't remember now. Already developing dementia. Dr. Aline Espiri.
Okay. Thank you very much for the presentation. The take-home message that I have is that porous implants are better than non-porous because they are well anchored and they have less risk of extrusion and migration. Thank you very much.
Yes, Doc. Thank you. Yeah, we don't have. I for one have not really seen the porous one. I've not even checked the prices. Yeah, but we might also try to delve in that aspect. We see, we get the quotations and see. Maybe some centers start with them and see how they're doing. Yeah, it's true. The chances of extrusion, I think, probably be much lesser because create the muscles in them. Yeah, so we might not only focus on what is really the cheapest. Yeah, I know maybe some of us who have kids or relatives who want the best for ourselves. Yeah, you'll be amazed that some of these things will just be maybe $10 and yet you have been avoiding. Thank you very much, Dr. Alinas. Dr. Brian, I think I'd mentioned that you give us one take-home message. Dr. Brian? Dr. Ngandwe?
Yes. So I'm saying my network is a bit poor, so I don't know if I'm clear.
Yes, we can hear you loud.
Okay, thank you so much. It was a very lovely presentation. I think for me, the take-home message is that we need to pay particular attention to the cosmetic outlook or outcome of the patients that we are treating for retinoblastoma or any other condition that requires that we should do a nucleation. For children, I think what came out strongly is that we need to keep the orbit continuously stimulated so that it keeps growing. And we have to strive to ensure that whatever the case, we look for an implant, at least for children, to keep the orbit growing. Otherwise, we might have very poor outcomes if we didn't make that effort. And it was also gratifying to note that there could be some implants that could be extremely cheaper, maybe at least to help us not to be scared, I think, to think about procuring them as we aim to treat children. Thank you.
Thank you. Yeah, just to comment also, anyone who'd want to come in and comment can just join. I've also noticed, I've not been doing a lot of eviscerations, but even with eviscerations, we've noticed that even in adults, if you just leave the eye like that, cosmetically, they don't look really nice. What you want is at the end of the day to achieve good cosmetic outcomes. You can imagine some of these things when you ask them, like patients who have squint or any defect on the face. There's actually a study that came out from Switzerland, where they had compiled what the patient's responses are. Some of them were complaining that they feel like everyone around is looking at them because of their facial defect. And some of them, when they arranged and asked, when they showed different people the pictures of individuals who have facial defects like strabismus, things like growth or defect, they noticed that there are high chances of getting married or finding someone, a partner to date with. So, and then to some extent, some people have gone ahead and committed suicide because of the facial defects. So even these patients who are coming with trauma and you are going to eviscerate, you can still put in a large implant, not necessarily for growth, but just, to make someone appear quite well. If you get some time, you go to YouTube and just search for 4-petal technique in the evisceration. Yeah, so it's going to guide, and that reduces a lot of extrusion. I've since been trying to I've used that on one patient. Actually, I didn't know that the reason why they came to me was specifically so that they can look nice. She's a musician, and the parents did not reveal. And the parents revealed that she's coming here for cosmesis. I don't think I was going to accept it because the pressure was too much. Yeah, so luckily, I tried the 4-petal technique, and we had an implant about 22 millimeters PMMA, and then afterwards, I used the 4-petal technique. You can look it up on YouTube. So the patient is looking nice. Unfortunately, I didn't take images. It would have been interesting to share before and after. Okay. Dr. Mvula, what has been your practice there? Which methods are you using, and what is difficult for you?
For now, we are not using any implants. Simply because we don't have them. But I think following this presentation, we'll try and get some implants and see whether that would be of help to our patients. Definitely, I'm sure the patients would love it.
Yes.
Maybe just a comment on the way our patients present. From the video and the presentation, I think using the implants is quite a good thing, and the surgery seems to be simple. But when I look at the way most of our patients present, most of them seem to present very late. I think, can you get me?
Yes, Doc, we can hear you.
Oh, yeah. Most of our patients present very late. I think in my few years of practice as an ophthalmologist, I've hardly seen a patient who has come with a tumor confined, which has spread out of the globe. Most of the patients I see, the tumors are quite extensive. So my suggestion would be maybe perhaps if we could sort of advocate for early diagnosis of these tumors, if we could go including checking for the red reflex on our under 5 cards, so that we can pick these tumors early. Because I tell you, I think most of the patients I see or I have seen have tumors which are really advanced, such that I don't think they can even benefit from an ordinary enucleation. Yeah, I think for me, my message is, I think let's find a way of trying to diagnose these retinoblastomas early, so that patients can have good outcomes. Yeah.
Yeah, it's interesting, Dr. Chero, that you have mentioned that most of the referrals I was getting actually is from Dr. Mbula's clinic and from Mansa. I don't really know what is in Mansa. The retinoblastomas that are there are really amazing. Yeah, I've seen a number of them. We don't even know what the diagnosis is up to now. Yeah, so like you have mentioned, actually, you are very right. We need to push for the subject of retinoblastoma is something that very large, that is very big. Yeah, but we should strive, I think, to try to find implants, so that even those patients who are enucleating or have eviscerations as a secondary to endophthalmitis, trauma, and other things, at least they go with implants, even if they are older, would want to achieve a best cosmetic outcome. Okay, so I'm not sure if there are any comments for now. We have done so far. We're supposed to end at 18 hours exactly, at least 18 hours exactly.
Maybe I can comment just a bit.
Yes, Dr. Mtoloki, and welcome. Yes, Dr. Mtoloki, I can hear you.
Thank you very much. Okay, the presentation was very good, but I'm wondering the next time, are we able to also critique the paper? It would be good that you also send us the paper in advance so that we can critique as we do the journal presentation. Otherwise, the science part was very good. Let's keep it up.
Yes, the paper was shared. I don't know maybe how you missed it.
I thought to download it. I don't know.
Okay, yeah. So I think we would encourage next time we encourage the rest of the presenters to share the paper time, so we can spend time on the critique. She did part of the critical appraisal, but we have not gotten that to the members. So probably maybe the members didn't have time to read. So we'd encourage everyone. The next presenter, I think, Dr. Lombe. I'm not sure either Dr. Lombe is in the group. Dr. Lombe is presenting on something also for beginning. Dr. Lombe, are you around? Okay, so the next presentation will be hosted by UTH. So we'd encourage the team at UTH. The best approach is, if there's a paper, the presenter does it and then discusses with the rest of the team at their host institution, so that you can go through. And then also you try as much as possible to share to everyone, so that everyone has access to the paper. And then you send a reminder also about the presentation. We really need to increase on the interaction. So we haven't had much critical appraisal from their members. about the paper. Yeah, but it's the beginning. We'll get there.
Okay,
Hello.
thank you.
Dr. Mumbi, can you hear me?
Yes, please. Yes, Dr. Paula, we can hear you. And thank you for coming.
Thank you very much. First of all, Dr. Silvia, a very good presentation, I must say.
Thank
And
you.
my question is, how many have you done the enucleations, and what is the method you use? And did you use implants in the patients?
That is for me?
Yes, please.
Yes. So in the past year, 2019, we had 8 enucleations done for retinoblastoma. And the practice here is that we are not using implants because of the poor chemotherapy support, but we are using the standard enucleation procedure, none of the ones that I mentioned. But we're looking at improving the practice. So this is just to remind us that there are techniques which have been proven to improve the outcome for the patients, which we should all endeavor to adopt. So currently that is the position.
Thank you for that. My take is that if we catch these retinoblastomas quite early, I have done a few where I've actually done a nucleation and put in an implant. And I've noticed that apart from the implant, you should also have a conformer like Dr. Mumbi was saying, because it's very important. Because if you don't have a conformer, even if you have an implant inside, the fornices will be so shallow so that you cannot put an artificial eye. And in the absence of an oculist, which we don't have here in Zambia, it will be very important for you just to use the best, nearest to the other eye, an artificial eye. Fortunately, I have a few artificial eyes, I have a few conformers, and I have got a few implants. So the ones which I have done, the outcome is relatively good actually because of those 3 things.
Thank you so much for that. Take a note.
You can come and pick a few implants. You are in Kitwe, no?
Yes, yes, Dr. We are in Kitwe. Thank you so much for that offer. Definitely will come through.
Thank you.
Thank you.
Thank you very much, Dr. Paula, for the offer, but we would encourage a sustainable way of doing things. So you might need to emphasize that you include it in your budget.
Absolutely.
Definitely.
Okay, yeah. Anyone has any comments as we close? I think we have already shot by 5 minutes. I think Dr. Funjika, any comments?
Yes, I think just to congratulate Dr. Sylvia on the good presentation. And then I think aside from a conformer, I've seen instances where you use a prosthetic eye in the fornices and then do a temporal tarsography just to keep the fornices deep. I don't know what your comment is, Dr. Mumbi, on this, because conformers are not readily available in our environment. So can you use the prosthetic eye temporarily immediately after the surgery?
I've never tried that one, Dr. Funjika. I'm hearing up to it for the first time. It would be interesting to explore that route.
Okay.
Yes, and then when the way the conformers are bought, the way the implants are bought, it becomes like a set. So when you're making an order, there's a separate for the conformer and then for the implants. And then what I noticed when we ordered that UTH, we are given quotations for the silicone ones and also for PMMA. The silicone ones were expensive. We went for the PMMA, yeah, and this is the reason why this article was presented, to show that even though most of the people in the West are using silicone, and I think there have been doubts about the PMMA, thinking that these ones are going to extrude. So they showed us with a large sample size of 321, they didn't find any of those negative things. So it's very encouraging actually that we have evidence that even the PMMA in our region, it still works.
Yes, the PMA does work, and I think the outcome was very good.
Okay. Dr. Mvula is raising a hand. Dr. Mvula, you have a comment?
Hello?
Yes, Dr. Mvula.
Yeah, it's just a matter of, it's a technical issue. It's just a technical issue that I wanted to suggest to everyone, that
Yes,
you
Dr.
need to be aware of, the issue of raising the hand during the meeting, so that we proceed very smoothly as we are discussing. So when you click where it says participants, on the right side at the bottom, you will see the list, below the list of the participants, you will see where there's a raised hand. If you click that one, you'll be alerting the one who is hosting, so that they'll be able to pick you out and ask you to comment or chip in, instead of people just joining in without being asked to join in. Otherwise, there will be a lot of echo.
Yes, Dr. Mvula, we appreciate. Thank you very much for that notification. Okay, so otherwise, I think we can close unless there's any burning matter. We have overshot by 8 minutes. We just want to thank you, Kitwe, for hosting us. And I love the image of your hospital. It really looks very nice. Yeah, when I was looking at the picture, I didn't think it was Kitwe.
Thank you very much, Doctor, for the support. Thank you, everyone, for your participation.
Okay, so we would recommend UTH to send the article in time, and then later on send a reminder. Yeah, I remember what Dr. Mtoloki mentioned, that most people did not receive it. It would be important. Information sticks more. So the next presentation actually will be talking about a very simple, not really very simple, but one of the commonest procedures that we do. This is on pterygium. Okay, it's something to do with conjunctival autograft, and we see how we are practicing. You know, these are some of the simple things that we may think simple, but imagine you do it and the patient keeps on coming to you because of the currents. Okay. Yeah. So if there are no comments, if there are no burning issues, we may close and join next week. If there are any suggestions on the meeting, please, you can forward them through either WhatsApp or you can email so that we can make it better.
Thank you.
Okay. Thank you very much.